Hi, I'm a Psych NP and I have a practice quiz for you on addiction psychotherapy. Ready? Let's learn psych fast. Question 1. A patient admitted for injuries that were sustained while intoxicated has been hospitalized for 48 hours. The patient is now shaky, irritable, anxious, diaphoretic, and reports nightmares. Pulse rate 130. Patient shouts out, "Bugs are crawling on my bed. I've got to get out of here." Select the most accurate assessment of the situation. The patient is A, is attempting to obtain attention by manipulating staff. B, may have sustained a head injury before admission. C, has some symptoms of alcohol withdrawal delirium. Or D, is having an acute psychosis. The answer is C, has symptoms of alcohol withdrawal delirium. So symptoms of agitation, elevated pulse, and perceptual distortions indicate alcohol withdrawal delirium. The other options are incorrect as they are inconsistent with as there's nothing definitive suggesting manipulative attempts, head injury, or functional psychosis. Question 2. A patient diagnosed with alcohol abuse disorder says, "Drinking helps me cope with being a single parent." Which therapeutic response would help the patient conceptualize the drinking objectively? A. Sooner or later, alcohol will kill you. Then what will happen to your children? B. I hear a lot of defensiveness in your voice. Do you really believe this? C. If you were coping so well, why are you hospitalized again? Or D. Tell me what happened last time you drank. The answer is D. Tell me what happened the last time you drank. So the correct response will help the patient see alcohol as a cause of the problem, not a solution, and then begin to take responsibility. This approach can help the patient become receptive to the possibility of change. The other responses directly confront and attack defenses against anxiety that the patient still needs. They reflect the provider's frustration with the patient. Question 3. A patient diagnosed with alcoholism asks, "How will Alcoholics Anonymous even help me?" Select the best response. The goal of AA is for members to learn controlled drinking with the support of a higher power. B. An individual is supported by their peers while striving for abstinence one day at a time. C. You must make a commitment to permanently abstain from alcohol and other drugs. Or is it D? You will be assigned a sponsor who will plan your treatment program. The answer is B. An individual is supported by peers while striving for abstinence one day at a time. So admitting to being an alcoholic and making an attempt to remain alcohol-free for a day at a time and receiving support from peers are basic aspects of AA. The other options are not correct. Question 4. Which medication to maintain abstinence would most likely be prescribed for patients with an addiction to either alcohol or opioids? A. Bromocriptine, B. Methadone, C. Antabuse, or D. Naltrexone. The answer is D. Naltrexone. So naltrexone is useful for treating both opioid and alcohol addiction. An opioid antagonist blocks the action of opioids and the mechanism of reinforcement. It also reduces or even eliminates alcohol craving. I include a little diagram for you to see the mechanism of action at the receptor site. Question 5. A hospitalized patient is diagnosed with an alcohol abuse disorder, believes that the window blinds are snakes trying to get in the room. The patient is agitated, anxious, and diaphoretic. What will you prescribe? A. A narcotic analgesic such as hydromorphone. B. A sedative such as lorazepam or Librium. Would you do C. An antipsychotic such as olanzapine or thyroidazine? D. An MAOI such as Nardil. Answer is B. You'll prescribe a sedative, as sedation allows for safe withdrawal from alcohol. Benzodiazepines are the drugs of choice in most regions because of the high therapeutic safety index and anticonvulsant properties. Question 6. Which feature should be present in a therapeutic milieu for a patient with a hallucinogen overdose? A. Simple and safe. B. Bright and active. C. Stimulating and colorful. Or D. Confrontational and challenging. Answer: simple and safe. Because the individual who has ingested a hallucinogen is probably experiencing feelings of unreality and altered sensory perception, the best environment is one that does not add stimulation. A simple, safe environment is a better choice than an environment with any of the other characteristics listed in the other options. The other options would contribute to a bad trip. Question 7. Which assessment findings are likely for an individual who recently injected heroin? A. Anxiety, restlessness, and paranoid delusions. B. Muscle aching, dilated pupils, or tachycardia. C. Heightened sexuality, insomnia, and euphoria. Or D. Drowsiness, constricted pupils, and slurred speech. The answer is D. Drowsiness, those constricted pupils, and slurred speech. Heroin is an opiate and therefore is a CNS depressant. Blood pressure, pulse, and respiration will all be decreased and attention will be impaired. The distractors describe behaviors consistent with an amphetamine use, symptoms of narcotic withdrawal, and cocaine use. Question 8. An adult in the emergency department states, "Everything I see appears to be waving. I'm like outside my body, looking at myself. I think I'm losing my mind. Vital signs are slightly elevated. What do you suspect? A. A schizophrenic episode. B. Hallucinogen ingestion. C. Opioid intoxication. Or D. Cocaine overdose." The answer is B. Hallucinogen ingestion. The patient who is high on hallucinogen often experiences synesthesia, which is visions and sound, depersonalization, and concerns about going crazy. Synesthesia is not common in schizophrenia. CNS stimulant overdose more commonly involves elevated vital signs and assaultive, grandiose behavior. PCP use is commonly causes that bizarre or violent behavior, nystagmus, elevated vital signs, and repetitive jerky motions. Question 9. According to Jelinek's classification of alcoholism, which of the following types refers to a person who has developed physical and psychological dependence but still maintains the ability to abstain if necessary? Is it alpha, beta, gamma, or delta? The answer is C, gamma alcoholism. So, according to Jelinek's drinking behavior is heterogeneous. He describes 5 species of alcoholism. Alpha, which is purely habitual use without loss of control, the person retains the ability to abstain. It's that problem drinker but does not have a disease at that point. Type beta refers to development of physical complications without physical or psychological dependence. Type gamma, that represents acquired tissue tolerance leading to physical dependence and loss of control. They still maintain the ability to abstain if necessary. Type delta shares the 3 features of gamma, but the inability to abstain becomes more prominent. Type epsilon, that refers to dipsomania or periodic alcoholism. More recently, various investigators have come up with different classifications which overlap each other. Question 10. The mortality rate in a person being treated for alcohol withdrawal delirium is A, 0 to 1%, B, 10 to 20%, C, 20 to 30%, or D, 30 to 40%. The answer is B, 10 to 20%. Alcohol dependence occurs in 15 to 20% of hospitalized patients in some settings. Hence, withdrawal from alcohol is also a common presentation in this population. Withdrawal symptoms are minor in most cases, but they can be considerable and even fatal in some. Alcohol withdrawal delirium, commonly known as delirium tremens or DTs, is the most serious manifestation of alcohol withdrawal syndrome. Classic studies quote a mortality of around 15%, but with advances in treatment, mortality rates have fallen, and more recent studies indicate a mortality of 0 to 1% in treated cases. Question 11. Failure to diagnose and failure to institute adequate thiamine replacement therapy for Wernicke's encephalopathy is associated with mortality of nearly, is it 10%, 20%, 30%, or greater than 50%? The answer is B, 20%. Failure to identify or consider Wernicke's encephalopathy and failure to institute adequate thiamine replacement therapy has been associated with a mortality of 20%. Wernicke's encephalopathy is an acute neuropsychiatric condition associated with biochemical brain lesions caused by the depletion of intracellular thiamine, also vitamin B1. Although reversible in the early stages, continued depletion leads to cellular energy deficit, focal acidosis, regional increase in glutamate, and ultimately cell death. Clinical features include delirium with prominent anterior grade amnesia, ataxia, ophthalmoplegia. Imaging may reveal the presence of small hemorrhages. Question 12. If left untreated, what percentage of people who develop Wernicke's encephalopathy goes on to develop severe, persistent amnestic syndrome? Is it A, 10%, B, 20%, C, 50%, or D, 75%? The answer is 75%. So in 75% of cases of Wernicke's encephalopathy, will be left with permanent brain damage involving severe short-term memory loss, which is also called Korsakoff dementia, if adequate parenteral therapy with thiamine is not instituted. In clinical practice, Wernicke encephalopathy may be difficult to recognize because all the classic symptoms might not be present. In addition, the symptoms may be colored by the presence of other comorbidities such as withdrawal, delirium, or seizures. Well done. Thanks for watching. Hope you enjoy this. Please share it with a classmate and please like or comment below. Thank you. Bye.